Welcome. We will get started in just about 1 minute. Welcome and hello. I'm Marcy Johnson. I'm the Assistant Director for Health Sciences Alumni Relations. We are glad you were able to join us for today's Virtual Health Academy. These events provide a unique platform to showcase groundbreaking research and advancements in the health sciences. Let's dive right into the topic and our presenters today. Dr. Stephanie Green is a nationally recognized expert in pediatric vascular neurosurgery and congenital neurosurgical disorders. She joined the faculty of the University of Pittsburgh's Department of Neurological Surgery in the Pediatric Neurosurgeon Division at UPMC's Children's Hospital of Pittsburgh in 2009. She is the Vice Chair of Education, Director of Vascular Neurosurgery and Prenatal Neurosurgery, and Director of the Pediatric Neurosurgery Fellowship at Children's Hospital of Pittsburgh. Allie Mullen resides in 84 PA with her husband and 3 little girls, Anston, Emery, and Reagan. Allie worked as a pediatric ICU nurse for 7 years and worked alongside Dr. Green at Children's Hospital before having the surgery with Emery. She recently moved into the stay-at-home mom role with busy days consisting of crazy schedules with her kiddos and helping run her husband's excavation business. Welcome, Dr. Green.
Thank you very much. I'm going to share my screen and get started. I have a lot to cover, so I'm going to talk a little faster. There we go. Okay. So fetal surgery was an established technique for patients in the United States beginning in 1982. The original surgery was performed for bladder outlet obstruction. The fatality rate of that condition is 90% because with the absent bladder, the lungs don't develop. So the fatality rate was rapidly decreased to 50% with this fetal surgery. There were many concerns on multiple fronts: safety, efficacy, ethics. And so the International Fetal Medicine and Surgery Society, the IFMSS, was established in 1982. Initial guidelines for fetal surgery included performance only for lethal conditions where the pathophysiology was understood and strict adherence to ethical guidelines. As maternal safety improved, considerations of conditions with only severe morbidity as opposed to lethality were considered. This is a list of the criteria for fetal surgery per the IFMSS. So following the initial establishment of the IFMSS, vesicoamniotic shunting was established for bladder outlet obstruction, Fetoscopic release of the obstruction began to be performed, and open fetal vesicostomy became a treatment option as well. Congenital diaphragmatic hernia began to be treated by the exit procedure, where the fetus remains on placental circulation until ECMO, extracorporeal membrane oxygenation, can be established, providing survival for this condition. Congenital pulmonary airway malformation, or CPAM, is treated with thoracentesis, thoracoamniotic shunting, or open fetal surgery. Sometimes these children are born via exit procedure with an emergency tracheostomy performed prior to separation from placental circulation. Twin-twin transfusion is able to be treated fetally with amnioreduction or selective fetoscopic laser photocoagulation. And myelomeningocele began to be considered. So here's myelomeningocele. This is the spine. Here's the defect. You can see nerve roots extending out toward the defect. Of course, nerve roots extending out toward the defect are not supplying leg or bowel or bladder function down at the bottom of the spine. This is an open myelomeningocele defect. This is called myeloschisis because it's flat. There's no sac here. Often there's a sac. This is the open neural placoid that should have been tubularized, but did not form properly. There's arachnoid around this, and dura and skin around the placoid. Sometimes myelomeningocele defect is almost entirely skin covered. Associated neurological conditions include hydrocephalus. The estimated rate of shunt placement is 60 to 90%, although more recent numbers are lower, closer to 60 than 90%, as people have begun to tolerate larger ventricular size in these patients. Chiari-2 malformation is present in every child that's born with an open myelomeningocele. That's different for patients treated prenatally, as we'll see. Chiari-2 malformation requires treatment only in about a third of patients. And that's done for symptoms such as apnea, weakness in the upper extremities, swallowing dysfunction. The Chiari-2 malformation is responsible for 15 to 20% of all deaths in pediatric myelomeningocele patients, most commonly from respiratory failure. Tethered cord syndrome, so this is a Chiari-2 malformation right here. Tethered cord syndrome requires surgery in about 20% of patients. Here you can see spinal cord tethering on the right. Tethered cord symptoms include back and leg pain, worsening bowel or bladder dysfunction, sensory changes, or even weakness in the lower extremities. Symptoms are most common during a rapid growth period, a growth spurt, or intense exercise. The symptom that's most likely to improve is urinary incontinence. The prognosis is known for myelomeningocele, but 75% of these patients have normal intelligence. The most common abnormal finding is a deficit in nonverbal intelligence. Up to 50% of patients have latex allergies. This was initially thought to be due to chronic latex exposure, but this allergy has persisted even after latex has been eliminated from the treatment of these children in hospitals. And it's now thought that this is just immunoglobulin E anomaly that's associated with the condition. 75% of these children can ambulate. Sometimes it's with assistance with bracing, but this number declines with age and with symptomatic tethered cord syndrome. The rationale for fetal surgery for myelomeningocele included the two-hit hypothesis, which was publicized in the 1990s. The first hit is the failure of closure of the neural tube, and the second hit is hypothesized to be ongoing injury as the pregnancy progresses. Whether it's mechanical force or toxicity of the amniotic fluid to the exposed neural placoid is not known. The classic treatment for myelomeningocele is palliative. We're not fixing anything, we're just closing the skin to the air. In utero closure was hypothesized to preserve the neurologic function that the obstetricians see on ultrasounds early in pregnancy that disappears later in pregnancy and following birth. Initial preliminary animal studies were supportive. Case reports demonstrated feasibility, but had mixed results. There were suggestions of decreased hydrocephalus and improved hindbrain herniation. This hypothesis led to the establishment of the MOMS trial, or the management of myelomeningocele study. This was a randomized controlled clinical trial intended to include 100 prenatal surgeries and 100 postnatal surgeries for myelomeningocele. The inclusion criteria were strict. Specific age of the fetus. They had to have a defect within certain levels. They had to have Chiari-2 malformation or hindbrain herniation. They had to undergo amniocentesis and have a normal karyotype, and the mother had to be an adult. Exclusion criteria were also strict. The presence of additional anomalies excluded the mother-infant pair from consideration of prenatal surgery. So everybody had to undergo prenatal MRI to exclude structural abnormalities. The presence of severe kyphosis was an exclusion criterion because that requires more time to close the skin. Patient who had had a prior preterm delivery was excluded. History of placental abruption was an exclusion, and the most common reason for exclusion in the trial is a BMI greater than 35. There was slow accrual of patients. The study was estimated to take 2 years initially, and it required 7 years to accumulate 183 subjects. The most common reason that a patient would decline would be the risk of preterm birth after they toured the neonatal intensive care unit at their institution. This study was performed at 3 centers, Vanderbilt in Tennessee, the University of California at San Francisco, and Children's Hospital of Philadelphia. All other pediatric neurosurgeons and maternal fetal medicine specialists agreed to a moratorium on this surgery so that the patients could be accrued within the trial as quickly as possible. Recruitment was halted after 183 subjects because of a clear statistical difference between the groups. This is sort of a cartoon of prenatal closure. So laparotomy is performed over the mother's lower abdomen. A hysterotomy is performed, exposing the infant. The obstetrician positions the infant so that the neural tube defect is within the incision. And then the neurosurgeon performs standard but quick myelomeningocele closure. We have about 45 minutes before the patient becomes hypotensive and surgery needs to be complete. So the standard closure for myelomeningocele involves dissecting along the junction of the arachnoid and the skin. You have to be very careful not to include any elements of skin because of the risk of dermoid cyst formation later in childhood. The dura has to be separated beneath the skin so that the dura can be closed. The dura is either primarily reapproximated or a dural patch can be sewn in for ease of closure. Patching is thought to potentially reduce the risk of tethered cord syndrome as well by providing a larger pocket of cerebrospinal fluid around the peritoneal plaque. The fascia is closed over the dura and the skin is closed over the fascia. This tube is flushing lactated Ringer's solution into the uterus because allowing the fluid levels to drop leads to trouble perfusing the baby because the umbilical cord is compressed. There's a lot of details to the surgery. The risks to the mother are the standard risks of a cesarean section. That's the reason that BMI greater than 35 was an exclusion factor, because the risks to the mother are higher with cesarean section if the BMI is higher than 35. And the risk of ongoing pregnancy in an operated uterus. You know, if a pregnant woman is in a car accident, she's likely to deliver early. And here we're asking her to not deliver early. So the risk of preterm labor is very, very high. The biggest risk to the infant is preterm delivery. The average infant in the trial was delivered at 34 weeks. The study was published in the New England Journal of Medicine in 2011. I'm going to summarize some of the results for you. I've put the red boxes around the important criteria. The rate of shunt placement was decreased from 82% to 40%, so it was cut in half. But if you look at the criteria for shunting, we went from 92% to 65%, so more decreased by a third. The incidence of Chiari-2 malformation was dramatically reduced on imaging. Severe Chiari-2 malformation went from 22% to 6%, moderate from 45% to 19%. So many more patients had mild PRI malformations, and 36% of patients had no PRI malformation at all. The benefit of that, though, is a little bit more unclear since only a small percentage of these patients require surgery for their PRI2 malformation. Another important point is that surgery for tethered cord increased eightfold. This is principally because of dermoid cyst formation at the site of repair. Outcomes of children at 30 months were published. This showed dramatic increase in motor function. The number of patients functioning 2 levels better than expected based on their anatomic level went from 12% in the postnatal surgery group to 32% in the prenatal surgery group. The percentage of patients that were 2 levels worse than predicted went from 28% to only 13%. The big improvements there. Behavioral scores were improved as well. The number of patients walking independently with postnatal surgery was 21%, and with prenatal surgery was 42%. That being said, a significant percentage of patients who underwent in utero repair did not benefit. Those patients who had no difference in anatomic and functional scores for postnatal surgery was 25%, and for prenatal surgery was 23%. A number of variables were analyzed in 2021. The important features of this study included that there was no decrease in shunt placement for infants with ventricles measuring greater than 15 millimeters. So that's now an exclusion criteria for prenatal surgery. Of those requiring a shunt, the number requiring a shunt revision is much higher in children with postnatal surgery than with prenatal surgery. This is hypothesized to be because the patients having prenatal surgery were able to wait longer before shunt placement with the corresponding lower levels of protein and discarded cells in the cerebrospinal fluid. Of note, the number of patients with normal bladder function is 24% in the prenatal surgery group and only 4% in the postnatal surgery group. The post-void residuals were noted to be smaller in patients undergoing prenatal repair. The number of patients requiring tethered cord release remains elevated. While the difference between postnatal and prenatal surgery was 1% and 8% in the short-term group, at school age, the rate of needing a tethered cord release is 15% in postnatal closure group and 27% in the prenatal closure group. So our first patient was Allie Mullen. She was considered to be an ideal patient for our first case. She was planning to have this be her final pregnancy, although she changed her mind, as you'll see. She was at the right stage of gestation. Her baby had a myelomeningocele defect at an appropriate level. She was knowledgeable about this. As mentioned in the introduction, she was an ICU nurse at Children's. And she knew she was first, and she was willing to be first. This is a shot of Dr. Emery, who is our maternal fetal medicine surgeon, who was involved in the prenatal surgeries with me, exposing the uterus during surgery. This is a picture of me on the left under the microscope and my fellow on the right under the microscope performing the prenatal closure. I have a little video that I'll just sort of talk over. So this is the myelomeningocele defect right here. Exposed, we're incising the arachnoid plane around the myelomeningocele defect. You'll see a gush of cerebrospinal fluid in a second. There we go. So that's circumferentially divided. We'll switch to scissors there to do that as quickly as possible. Now we're dividing the dura around the margin. Once the dura is separated from the surrounding subcutaneous tissue, we'll use a syringe of irrigation. We'll put it in the epidural plane and it will do sort of a blunt dissection of the dura away from the surrounding soft tissue. So it enables us to free the dura more quickly and tubularize it. more rapidly. Final cut there. That's gel foam with thrombin used for hemostasis. Here comes the syringe of irrigation, dissecting the dura. And we're dividing the dural margin. So just for some perspective, I'm going to show you, this is a dural patch being shown in a second, you'll see Dr. Emery's thumb on the right side of the screen. That's the degree of magnification we're operating under. He's holding baby Emery inside the uterus because with the ingress of fluid, the baby is sort of naturally trying to be extruded from the uterus. So we'll complete that dural closure. And we will apply a little bit of fibrin sealant glue to decrease the chances of cerebrospinal fluid leak. And then we'll see skin closure and be at the end of the video. This surgery takes about 20 minutes. I think our video is about 2.5 or something like that. So some parts are omitted. That's not including the hysterotomy, but just the neurosurgical portion. Skin is closed with a dissolvable protein suture, and it's gone by the time of delivery. There's our fibrin glue going in. And final stitch. I guess I have to go to the end to go to the next page. So postoperative course, Sally was hospitalized for 4 days. Serial ultrasounds demonstrated normalization of anatomy. Here you see prenatally the lemon sign where the skull takes on sort of the shape of a lemon with an indentation on the sides. It becomes long and narrow. And this is 2 weeks, maybe, postnatally. The round shape of the skull is restored. This demonstrates the banana sign seen behind the cerebellum and normalization of that on follow-up ultrasound. And Emily was delivered at 34 weeks gestation. On the left, you see a standard postnatal closure incision. On the right, you see baby Emery's incision before she was discharged from the hospital. So skin closure looks much nicer after this kind of surgery. This is Allie in the center, together with Dr. Emery from maternal fetal medicine and me. Allie and her husband decided to name their baby after Dr. Emery and me, which I'm still so incredibly touched by. Emery has done great. She has full motor function with the exception of the ability to point her toes down. She has no hydrocephalus and no flights in office. A little picture of her. I have a little video that Allie sent me. She's a couple years older than this now, but here she is walking. I think I probably need to ask for some new pictures, but you'll see her today. Another little video. Emery with her big sister. And Finn. She's a much better walker now. So in summary, myelomeningocele is a diagnosis that carries significant morbidity. The risks and benefits of prenatal surgery are complicated and they need to be discussed in an individual fashion. Evidence suggests that prenatal closure improves outcomes on several fronts in some patients. Prenatal surgery, just like postnatal surgery, does not cure the condition, but it ameliorates it significantly. many candidates are not, many patients are not candidates for prenatal closure. I think I want to turn the screen over to Allie for a little question and answer session. I'll just mention some current controversies. There's a move to perform fetoscopic surgery in comparison to open repair. The idea is that it's less disruptive to the uterus, and indeed decreased uterine dehiscence has been reported. The risk of preterm delivery is actually a little bit higher thus far with fetoscopic surgery, and the risk of insufflating the uterus with carbon dioxide is not known. Overall, the surgical time is much longer for fetoscopic surgery as well, and the risk of pseudospinal fluid leak appears to be a little bit higher. The other controversy is exclusion criteria. Are the exclusion criteria too strict? Are we eliminating some patients that would be helped by this? I'm going to stop sharing my screen. After we talk with Allie, I have a presentation about some current fetal surgery research that we're performing at the University of Pittsburgh Medical Center.
Let's see here.
Why is it over a princess dress?
Hi, Allie. Hi, Emery.
Hello.
How are you today?
We are good. Sorry, I'm readjusting my screen.
It's okay. Did you want to talk a little bit about how Emery's doing?
Sure. Let me get. Do I need to share my screen? I'm sorry.
I can see you. Do you have
Okay.
some slides you want to? If you have slides, you would want to share your screen. Otherwise, I think.
No, it's just us today.
Okay. Okay.
You're all good. Yes.
Okay. All right. Hi everyone. My name is Allie Mullen, and this is Emery, and we are excited to be here today. I know Marcy's told you guys a little bit about me. I live in 84 with my husband and my 3 girls. Okay, remember. Okay, sorry. And I used to work as a nurse in the pediatric ICU at Children's Hospital. Emery. Come on. In December, actually, it was 4 years ago. In the first week of December, at 21 weeks pregnant. Our world was flipped upside down. Emery was diagnosed with the most severe case of spina bifida. She had a myelomeningocele at her L4 to L5 vertebrae, a spot where her neural tube did not close. The next day, we headed down to McGee to confirm the diagnosis and decide on what our next step would be. We had so much testing. We met with several doctors. And ultimately, a genetic counselor provided us with all of the options, including surgery to repair the spinal cord in utero. Through this process, we had learned that 68% of the babies diagnosed with spina bifida were terminated in utero. This was extremely shocking to us, especially because we were going through what so many others had gone through. But still couldn't bring ourselves to make that decision for our baby. We believed we had hope. We believed we could be different, and we felt in our hearts that this little baby was brought to us for a reason. Once we met Dr. Emery and Dr. Green, we knew that we were making the right decision for us and our family, that McGee and Children's combined could give our baby her best outcome. She is the most sassy, very determined little girl. She recently just started preschool at the beginning of September, and she's doing absolutely amazing. Excuse me. Emery, please leave her alone. Okay. Sorry, she's being a big sister to her little sister. But she has exceeded everybody's expectations. She runs, she walks, she plays. She's started tumbling class this year and dance class and absolutely loves it. We've been able to avoid the hydrocephalus as well as Emery, please. as well as the Chiari malformation on top of the only thing that we really deal with medically is her bowel and bladder, which we knew going into the surgery was not going to be was not going to change much either way. I'm sorry. Stop. So very sorry.
You're fine.
Sorry. Emery, do you want to join us or are you going to cry? Come on. But as you can see, she's living up to her description. She has again exceeded every expectation that we have had for her and more. What Dr. Emery and Dr. Green have done for us and have continued to do for other families, there's no way that we could ever say thank you enough. They have done everything for us in each and every way. I don't know where my life would be without this little girl, and I'm glad that Dr. Emery and Dr. Green are in our lives, and we made the decision that we did that day. It definitely was the best one that we could have made for her.
Thank you, Allie. Hi, Emery.
Say hi. Get up and say hi. Now you can take over the screen. Say hi. All right.
Thank you.
Thank you so much.
You're gonna say bye.
Bye-bye.
Bye-bye. I hope you can hang around till the end and maybe people might have some questions for you.
Yeah, if there's any questions at the end, Allie, we'll.
Okay. All right. I'm gonna mute.
Okay, thank you guys so much for being here, and thank you for your kind words and making us look good.
Thank you for having us.
Of course.
I'm going to share my screen again and move on to the research part of the talk. So Dr. Emery and I have continued our collaboration on the research front. We've been working about 5 years now to treat fetal hydrocephalus in utero. This is roughly called ventriculoamniotic shunting. I talked a little bit about vesicoamniotic shunting already. So that led to the attempt to perform ventriculoamniotic shunting in the 1980s. The results were pretty dismal, but many of these prenatally shunted cases turned out to have other significant abnormalities like hydranencephaly, Dandy-Walker malformation, fatal genetic syndromes. So the results weren't great, but patient selection was poor, and the surgical techniques were not well developed. The largest series that had been reported historically was only 44 patients. The only subgroup of patients that benefited from shunting was that with isolated aqueductal stenosis. Isolated aqueductal stenosis occurs in about 3 in 10,000 births, which translates to about 400 births per year in the US, 14,000 births per year worldwide. As mentioned, there were problems with patient selection and technology. The shunts migrated, they were obstructed. In terms of patient selection, the incidence of other congenital anomalies ranged from 70 to 84%. There was no clear benefit given these issues with selection and technology. So moratorium was placed on treatment of fetal hydrocephalus in the mid-1980s by IFMSS. And there was pretty much no progress since. The prognosis in fetal surgery can be defined in several ways. High resolution ultrasound has been a step forward. MRI exists now. Next generation genetic testing has become routine. There's now successful fetal surgical experience with myelomeningocele. Multi-center collaborations have been established. The MOMS trial I've mentioned already. The North American Fetal Therapy Network I will mention a little bit later. It's a network of hospitals around the country performing fetal surgery. A little bit about the effects of hydrocephalus on the developing brain. Animal studies have demonstrated multifactorial brain injury. There's mechanical distortion, where the brain is distorted around the enlarged ventricles, which leads to shearing or tearing of the axons in this area, which then scar. There's impaired cerebral blood flow, which leads to ischemia. These things affect normal neuronal migration in the brain. They are impacted by the gestational age of onset, by the rate of ventricular enlargement, and by the etiology. Is there a tumor? Is there a vascular malformation? Is it isolated aqueductal stenosis? Shunting was demonstrated in 1993 in animals to incompletely reverse these findings. The potential for reversal diminished as the duration of hydrocephalus increased in this 1993 study. Mike Edwards from UCSF performed this study in fetal monkeys back in the 1984. What he showed was the hydrocephalic animal is on the left. He showed that the cortex was thinner, the subcortical white matter had fewer fibers in it, and there were foamy macrophages, which are trying to absorb dead tissue. So, criteria for fetal surgery according to the IFMSS. The first is that accurate diagnosis and staging is possible with exclusion of associated anomalies. So, Dr. Emery published this paper demonstrating that accurate diagnosis was possible. He used a database from 2006 to 2013 and analyzed the ultrasounds and MRIs prospectively. These were then compared with postnatal imaging. The gestational age at diagnosis of isolated aqueductal stenosis was a median of 24 weeks and 4 days, and by MRI, 31 weeks and 3 days. He came up with 12 subjects that had aqueductal stenosis, half of whom had isolated aqueductal stenosis, and half of whom had other congenital anomalies. So just a quick set of pictures. This is prenatal ultrasound, prenatal MRI, and postnatal MRI. Of course, there's a lot more detail in the postnatal MRI, but all of these show aqueductal stenosis. Here's lateral ventricle, third ventricle, aqueduct obstructed, fourth ventricle, and then the outflow where the cerebrospinal fluid migrates out to the surface of the brain for absorption in the arachnoid granulations. So he found that they could diagnose isolated aqueductal stenosis 100% of the time, and the other abnormalities were also identified 100% of the time. These abnormalities included cerebellar hypoplasia, septal dysplasia, intraventricular hemorrhage, and a tectal mass. So genetic syndromes need to be excluded according to that criterion on the IFMSS website. Multiple genetic abnormalities are known to be associated with aqueductal stenosis. There are X-linked syndromes, the most well-known of which is L1 syndrome or X-linked aqueductal stenosis, also known as crash syndrome. That name has fallen out of favor a little bit, but there are 200 known mutations in the L1 CAM gene. And this makes up about 30% of aqueductal stenosis cases. There's another X-linked gene, AP1S2, was identified in 2014. It's associated with Bandy-Walker malformation, developmental delay, etc. There are autosomal recessive conditions, more are being identified all the time. There are and more are being identified all the time. And so we won't know what all of these conditions are. Prenatal testing became widely available around the year 2000 though. The next criterion is that the natural history of disease, including the prognosis, is known. So the most recent study we could find was from 1995 by Levitsky et al. They described normal development in 24 to 86% of patients. He described 30 infants diagnosed in utero by ultrasound and a 40% mortality rate, which is pretty shocking. 8 infants died in infancy, all had other congenital problems such as TB, fistula, ventricular septal defect, renal agenesis, etc. Only 10% were described as neurologically normal. 73% of these patients had moderate to severe developmental delay described at a mean of 36 months. we decided to perform a current study of natural history. So this is our group that you can see. We studied, excuse me, 41 patients between 2005 2013, with mean follow-up of 6 years. Genetic conditions were excluded from the analysis. So these were cases with isolated aqueductal stenosis, treated with contemporary management. 71% were diagnosed in utero. About 60% were delivered by cesarean section because of the size of the infant's head. And 39% were delivered prior to term, being defined at 37 weeks. Our study identified 68% with developmental delay. Almost 80% required an individualized education plan when they went to school. About 50% had epilepsy, 10% had spasticity, and 15% had ADHD. So we saw significant room for improvement with prenatal intervention, potentially. We would describe that as current postnatal therapy being relatively ineffective. Those were patients treated with maximum current treatment. Feasibility and effect are demonstrated in the animal model. That gets to the meat of our talk. So here's a prospective analysis that was established through the North American Fetal Therapy Network. This is an association of 33 medical centers, including the US and Canada, with fetal surgery expertise. It's a cooperative network studying natural history and developing prenatal therapies. We proposed a multi-center prospective observational study in 2015. Primary outcomes were correlating prenatal diagnosis by ultrasound and MRI with postnatal imaging, and to determine the gestational age at which aqueductal stenosis can be reliably diagnosed. We decided to use NAPNet because this is a relatively rare disease. We are able to identify cases faster by using multiple centers. There's also scientific oversight and transparency. This is an evidence-based scientific approach. There's no competitive research being performed. Everybody within the network is supportive of this study. It's got a track record of NIH funding, so it enables this study to more easily get NIH funding. And most importantly, only NAPNet can overturn the moratorium on fetal surgery for isolated aqueductal stenosis. The study methodology included secondary outcomes, outcomes of the pregnancy, gestational age of delivery, indication for delivery, route of delivery, et cetera, as well as pediatric outcomes, mortality, prematurity, need for treatment, being a shunt and stop at third ventriculostomy, development, seizure disorder, et cetera. So the ultrasounds had multiple data points collected, the MRI the same. And the population is studied for 2 years to assess developmental outcomes and to use this as a historical control for future interventional trials and to plan an open label study for treatment. So feasibility and effect are demonstrated in the animal model. Sheep are a nice model to use for fetal surgery because they usually have twins. So you're able to generate hydrocephalus in both fetuses. We began using 90 days as intervention point, which equates to late second trimester, early third trimester in sheep. We injected a kaolin suspension into the posterior fossa initially, as was done by Dr. Edwards in 1995. And then we switched to bioglue, which is sort of a fibrin glue. One of the fetuses is shunted. We started out at 120 days. We've changed that a little bit over time. But that gives us a control animal even in the same uterus. They undergo cesarean delivery at 145 days. The brains are studied with high resolution MRI and pathologic analysis. We published on this in 2018, the histologic appearance of the untreated fetal animal model using just publishing on the pathologic findings in the animal brain. So we published results on 4 hydrocephalic fetal lambs and 2 controls. In this study, hydrocephalus was induced at 95 days gestation, and the brain was analyzed at term. We identified deep white matter damage, loss of axonal projections, and delayed maturation of the gray matter. Here you see the ventricles are dilated. The corpus callosum that should communicate between the two hemispheres is absent. On this slide, you see neuronal staining. The control animal on the left shows a normal laminar cortical ribbon. The hydrocephalic lamb on the right shows immature columnar appearance of the neurons. So we started working on a ventriculoamniotic shunt to treat isolated aqueductal stenosis in utero. We collaborate with Young Jae Chun, who is a bioengineer at the Swanson School for Engineering. He's part of our research group. And he has been working hard to make the ideal ventriculoamniotic shunt. We wanted the shunt to be able to be inserted percutaneously to limit the risks to the mother and the risks identified with the mom's trials, such as uterine rupture. The shunt is designed to be inserted under ultrasound guidance. It needed to be very narrow. It needed to have an anchor both inside and out of the skull to prevent migration into the brain and out into the amniotic cavity. It needed a one-way valve. Having amniotic fluid inside of the ventricular system would be catastrophic to the developing brain. It needed to be low profile because fetuses have been known to reach up and pull something out of their head, according to Dr. Edwards' initial study in the 90s. So this needed to have an angle to it and be short. It needed to not fail during the estimated survival time, which would be about 4 months after placement, if we intervene at a similar stage as we did during the mom's trial. So the shunt design has been refined a couple of times. It has all those features that were initially identified. We were able to demonstrate that earlier shunting produced better preservation of neuroanatomy than shunting later. And we're preparing for an FDA application for humanitarian use exemption. There's some pictures of these are the anchors. They're made of nitinol. Here's the one-way valve on the shunt. It opens to allow egress if the pressure is low enough. It's in a closed state. Here we are putting a shunt in a fetal lamb. That's me on the left and Dr. Emily on the right. Here's an animal model in MRI. This is a control animal that does not have hydrocephalus, just demonstrating that we can obtain accurate fetal MRI, accurate MRI of the fetus after delivery, I should say. And we've published on this in vitro and in vivo assessment of the shunt. This figure A is a demonstration of the diameter of the shunt. You note the right angle turn in the shunt, which enables it to sit close to the skull. There's an image of a hydrocephalic lamb with the shunt in the ventricle. Here's a harvested anchor with tissue growth around it, showing that it was stable in place. Here we can see the anchor, the internal anchor, showing that there's no tissue growth around it, but that it is secure in the skull with partial tissue growth outside of the skull by electron microscopy. This is the same shunt here in figure D with those three images around it. Here's the tissue growth at the level of the skull, but no obstruction internally or externally. The shunt tube is patent at the time of harvest, and there's minimal accumulation of debris. Here's the shunt just emerging slightly from the skin, no degradation of the function of the valve over time. So here are some images of the fetal sheath during the process. So top left is a baseline image of the fetal brain without hydrocephalus. On the top right, induced hydrocephalus. Bottom left, you can see the shunt inside of the hydrocephalic ventricle. Bottom right, you can see the shunt. It's a little harder to see because the fetus is getting older during these pictures, but you can see the shunt within a decompressed ventricle. So we've achieved proof of concept with that study. We are at the stage of completing the animal model, by which I mean we need to show that the proof of concept is reproducible. We need to publish on the pathologic findings showing that the damage caused by the hydrocephalus is reversed. The MathNet study that began in 2015 needs to be completed. We're working on identifying a partner in industry. We're still refining and finalizing the design. We've changed it enough that we have 2 patents already. Then we will seek FDA approval with the humanitarian use device exemption. And we will begin manufacturing. We will then pursue an open label trial with the assistance of MathNet. The members of MathNet have agreed, similar to the MOMS trial, to not pursue treatment of this condition while we are investigating this treatment so that we can accrue patients as rapidly as possible and determine whether this treatment is ideal or not. We are working on the postnatal treatment. So these, when we begin to do this in humans, these babies will need to be delivered by a cesarean section. And the shunt will need to be connected to a cerebrospinal fluid collection system to reduce the risk of infection until the infants can be transferred over to Children's Hospital of Pittsburgh for definitive treatment. Definitive treatment will be either endoscopic third ventriculostomy or ventricular peritoneal shunt placement within several days of birth. I think that's everything I have for you. I appreciate your attention, and I'd be happy to answer any questions.
Yeah, if anyone has any questions, please utilize the Q&A function and we can get those answered. So if any questions for Dr. Green or Allie.
Marcy, I lost your volume.
Can you hear me?
Yes, now you.
Okay. We'll see if any trickle in. And this will be recorded and sent out when also to everyone that registered, as well as on the Health Sciences YouTube page. Any questions? We'll give it just a minute. I don't see any trickling in, but if anything were to come up, please feel free to email us. Let's see here. And again, we want to sincerely thank Dr. Green and Allie and Emery for joining us today. We appreciate your time for the Health Academy. Okay. So again, extending our sincerest thanks for their remarkable knowledge and stories. We look forward to seeing you at future Health Academies in 2023. Until then, we hope you have a wonderful holiday season and a bright new year. Thank you, everyone.
Thank you.